So this is a very unusual case of a 72-year-old retired fighter pilot, and so with a normal LV, a very high calcium score, comes in because of his family history to ensure that he's not got any critical narrowing. He had one episode of severe shortness, sweating with some sort of pain. This one episode a few weeks back, which induced him to get a CT angio, which showed a calcium score of around 3000. So he opted for an invasive angiogram. The right coronary artery is relatively okay and is a little bit ectatic, and apart from that, nothing much. So ectatic artery is a non-smoker, non-diabetic, ex-smoker, 50 years back maybe. So the left system had, there was a little bit of narrowing in the left main, nothing much. There was some narrowing here and in the LED and the severe narrowing. This narrowing we thought was not very severe looking at it in some directions, and so we didn't think that this was very severe, this one here. The left main, we again looked at it in other views and didn't think. The circumflex had ectasia, a little bit of sort of dilatation, but the LED had a severe narrowing here post this little bit of aneurysm and little bit of narrowing here. The diagonals were fine, and this was the distal LED was okay. On this view, the left main didn't look much, but maybe this was around 50%. We reported it as 30 to 40, keeping this dimension in view. The LED here again was not severe, and in diastolic frame we didn't think that this was severe. But this LED part and this was severe, and we looked at it in another view, and you could see that in this view it did look quite severe. The left main was not that high, was not that narrowed, and we thought there was enough reflux and there wasn't much narrowing. There was some proximal narrowing here, a little bit of plaque there, which we thought may be significant, and a severe narrowing here. So this was, and the circumflex system was relatively okay. So this was his angiogram, and we took a couple of other views also, just to ensure that we do confirm what we are debating. So two narrowings, distal, mid to distal LED, nothing severe in the proximal part, and left main, which was nothing to write home about except for a plaque. So nothing very serious. Went out, counseled. There was a little bit of narrowing in the circumflex osteum, but nothing. There's a lot of calcium around, and we looked at it subselectively at the LED or at the left main osteum. Part 2 of this case, the 72-year-old fighter pilot. So we thought that, okay, fine. We counseled the family, and they all suggested and agreed that we should fix these two narrowings and leave the rest on medical treatment in this relatively asymptomatic person with just a high calcium score and one episode of chest pain. So we did balloon it, and we did the balloon opened up well. We did this was a 2 millimeter, and then we did a 2.5, and then we decided that we are going to put a dep here. So we did a dep here, and so a couple of repetitions, and so the result was acceptable. As you can see, the narrowing remains here, more mild to moderate. This was okay, 20-30% residual, but the area where we ballooned was okay, and nothing much to write home about. Maybe a bit of spasm distally, but the area that we ballooned and put a drug-eluting balloon was okay, and this is what we thought was the final result, and we left it as such. So this was the left main, seemed alright, everything else seemed alright, and the procedure was simple, straightforward. So 15 minutes after this procedure happened, and we had also taken, a few, there was a little bit of residual back here, but we didn't think that we needed to do anything. This was about 5 minutes after the original opinion, but this was looked at. We sort of changed over to diagnostic just to make sure that it's still open and everything else, 10 millimeters. So we did have nothing much here, but a 50% residual here. But we thought that there's no point in fixing this with a stent. Maybe this should be left alone. Right or wrong, the patient was shifted back, and 10 minutes later he started sweating and had chest pain, and I was called in. He was sweaty, he was quite unwell, and I was having a little bit of chest pain, and we got an ECG which was broad complex evolving MI, and patient was going into shock. So this is what the ECG, we'll just show you the ECG, and that's how it happened about 10 minutes later. Rushed the patient back into the cath lab. By the time we got him down, put him flat, started catheterizing his bladder, and preparing his groin. Now he started feeling very uncomfortable, sweaty, loss of consciousness, breathing became heavy, he wanted to sit up, was going into pulmonary edema. We sort of started the protocol, coded him. His pressures had gone down from 130 to 90 and then to 70, and his breathing was very labored, and then he stopped breathing. We intubated him, and while we were intubating, the pressure we put in a sheath, the pressures were 60 systolic, broad complex, and so I quickly intubated him, and this was the wires, 2 wires, and you can see that the heart is at a standstill, and the CPR you can see is going on. So this is CPR going on at the moment, and his heart is not moving. Managed to get 2 wires in, and the artery was definitely, there was nothing there. I stopped the CPR, and then this was all this was. The first picture we took on the fluoro showed that there was nothing going in at all, and again this one there was nothing going in. We had just blindly put in the wires and did some balloons. So the CPR was going on, and so we put in the balloon. We ballooned it multiple times in various areas. First distally, we had not saved all the fluoros, I'm afraid, and then this was about then the rhythm started coming back. He was on full blown inotropic, double inotropic or triple inotropic dopamine, dobutamine, norepinephrine and dopamine, triple support, and his pressure. Then you can see that there was something wrong here. The left main looked all right. Don't know what happened here actually. Maybe a thrombus here, but couldn't have had this occlusion here, which would have then caused an anterior MI, not this condition. So we can debate this as much as we come on to later, but you can see from this that there was still flow down here. This was not a closed vessel, but something had happened here initially on the initial. If you go back and look at it, the original picture, there's this is sorry, I'll just go on the original before. This is the first picture. We took some fluoro on this, and there wasn't anything going. You could see the wires are totally still, and then the CPR, then little bit of blood flow, and then we started ballooning. Little bit of blood flow started coming back, and so we kept on ballooning, and we put a stent in the distal vessel, and then did some ballooning in the proximal and put a big stent here. So we had stented all this, and we put a stent here. Not everything is shown. So we put a 2.5 stent here, and the heart started coming back, the pressure started coming up, something started moving. We put in a 3.5 18 millimeter stent here, and then ballooned it with a 5 millimeter NC, then put in another stent in the middle, and so things started looking a little bit better, and you could see that there was still, the stent was fully opposed. And so in any case, the patient started, we had intubated him, sedated him, then wanted to open the start up of this, so we did a kissing, everything, final pot, and I decided that I'm not going to leave it anything to chance, so all the NCs, and so this looked a little bit narrowed here, so we put in another stent on top of that, and so we had now stented all the way into proximal LED, and I sort of did the NC, and so this was the final shot, and this was the final shot, the cine, and you can see that this looks okay now. We haven't crossed this aneurysm, so we got a stent all the way down here, all the way down here, 5 millimeter, 3.5, 4 millimeter here, high pressure here, 2.5, and then optimized with 3 millimeter. All the circumflex is back, and the clot is seemed to have gone on agrastat, and so this was the case, and so we just wanted this picture to see there's no pericardial effusion or anything. So in any case, so it's kind of a 1 in 1,000 case where I'm not sure what exactly happened. Maybe we abraded this area and caused thrombus here, maybe this ruptured, or maybe in the where we ballooned here, maybe there was some thrombosis there and the backflow stopped or whatever happened. But in any case, the patient was in full-blown cardiac arrest, and subsequently his surprisingly we did an echo and his LV was perfectly fine, no wall motion. I'll show you that pre and post, and his ECG is recovered. Now it's been, it's 6 hours, 8 hours post. He's intubated, maintaining pressure on a single inotrope, and hopefully he would recover if God willing, everything, there is no new complication. But a case that I will remember that, and everyone should take into notice, that no angioplasty, however simple, is simple, and you need to be careful with everything. So this is the final result, and so let's hope this patient remains well long term. So this is his echocardiogram, which is fine, and all segments are working. There is no significant wall motion abnormality. The dimensions are fine, and they seem to have recovered without any myocardial hypokinesia or loss of myocardium. So this was very reassuring. As you can see, all segments, this is short axis, all segments are working. This was quite surprising to us, but in any case, this is good news that his LV was fully preserved, but he had to be intubated for a couple of days. It turned out that he was still smoking 23 cigarettes a day and hiding it from his family. Therefore, it took 48 hours for us to extubate him, but this is his echo pre-discharge, post immediate PCI echo was the same, and this is pretty good news.